and welcome to today's Talking Point. My name is Victoria Manning. I'm a professor in addictions at Eastern Health Clinical School, Monash University, and head of research and workforce development at Turning Point Eastern Health, and will be facilitating today's talk titled MOXY, an open-label pilot study of oxytocin for methamphetamine withdrawal in women. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past and present. I extend that present to Aboriginal and Torres Strait Islander peoples listening today or in the future. We recognise the lived and living experience workforce and all people accessing our services as their expertise, partnership and experiences help us shape services that are safe, accessible and inclusive. Talking Point is a regular series of publicly available lectures that aims to inspire, inform and challenge our notions of what we know about addiction and its impact across society. We like our webinars to be as interactive as possible, so please do ask questions via the Q&A function and we'll aim to answer those at the end of the presentation. Our webinars are recorded and are made later available on the Turning Point website. So I'd like to introduce today's speakers, Dr. Sarah Catchlove, Research Fellow at Turning Point, and Associate Professor Shalini Arunogiri, Clinical Director at Turning Point Statewide Services. Dr. Sarah Catchlove is an early career researcher with a background in psychopharmacology, sleep, cognitive neuroscience, psychophysiology, and neuroimaging. Sarah is currently overseeing several clinical trials exploring novel pharmacological treatments for substance use disorders. And Associate Professor Shalini Arunogiri is Clinical Director at Turning Point and the Hamilton Centre, and an Associate Professor and NHMRC Emerging Leader at Monash Addiction Research Centre. Shalini has over 60 peer-reviewed papers and over 20 million in research funding as a chief investigator on studies for novel treatments for substance use disorder, and her work focuses on addiction and related mental health comorbidity. Okay, so I'm going to hand over to you now, Shalini. Thank you.
Thanks so much, Vic, and thanks everyone for joining us today for this presentation. It's my pleasure to be able to discuss this study, and I'm working with Sarah, who is going to be co-presenting with me shortly. So I'm just going to get kicked off. As we've already talked about, we'll have the slides available for people after the presentation. So if you are interested in any of the detail, we'll send that out later on. So just to kick off with some disclaimers and some acknowledgements. First of all, really to acknowledge that the work we're going to present today was conducted on Wurundjeri land at our Turning Point Richmond site, and that the work was supported by a research grant from the National Centre for Clinical Research in Emerging Drugs, NCRED, quite some years ago, actually. So this was prior to COVID. And as we'll discuss with the study, like many research studies, affected to some extent by COVID as well. So we're really grateful for that funding and for the support of NCRED in being able to undertake this relatively novel study. Also acknowledging that I'm supported by an NHMRC grant, which allows me to be able to do this work and other work, and also that I've received speaker honoraria that are unrelated to the work presented today. Acknowledging the work of our broader team as well in the work we're going to discuss today. So we have a clinical and research team that's really interested in sort of innovative approaches to care, including medication sort of treatment approaches and psychological treatment approaches. We had an investigator team that formed a few years ago when we first got the grant for the study, but also our team has grown and evolved over the years to include a range of multidisciplinary researchers, our study coordinators, research assistants, and research nurses all acknowledged this. I really wanted to acknowledge everyone's work in contributing to what we're seeing today, and also acknowledging right at the outset the patients and support of the trial participants during the study who were really supportive of our work as well, and really wanted to kind of contribute to evidence base in this area of methamphetamine. So we'll tell you a little bit about what we did. So to start off with, some people in the audience might be familiar with oxytocin and what it is. And partly that's also from what we understand from childbirth and from delivery. So oxytocin is a naturally occurring neuropeptide, and the kind of research and understanding of the role it plays in human kind of behavior and thinking and bonding has kind of really grown over the last decade. And so traditionally, oxytocin, or the IV formulation, the intravenous formulation known as syntocinon, has been used during delivery to induce labor. So it can be used to bring on those abdominal sort of contractions that start labor and the start labor process. It also plays a role in sort of the letdown reflex and breastfeeding. But we also know that it plays a role in sort of bonding. So an image there, for instance, with parent bonding, early childhood, is a significant kind of role that oxytocin plays in that bonding behavior. And we're also starting to unpack that role that it plays in bonding behavior in both male and female parents in that process as well. In animal research, this has a huge role to play. And in terms of their impact on social relationships and social behaviors, particularly studied very cute prairie vole that we have on the image. Prairie voles mate and bond for life. And in that kind of example, there's a lot of research and literature that we can kind of draw from in terms of how bonding and relationships occur in that environment. And so really understand that key role that oxytocin could play within that context. And what we've learned, I suppose, from those different lines of research, both in animal research and in human research, is that oxytocin is a range of quite complex kind of systems that it relates to. We have sort of central processes within the brain that are triggered by oxytocin and modulated by oxytocin. And then we also have some peripheral actions through the rest of our body. This is kind of heavily medical, the terminology used here, and kind of highly, kind of gives you a bit of a sense, I suppose, of the different ways in which oxytocin can play a role. And sometimes you see this in a couple of slides, I'll kind of highlight the fact that this can sometimes be referred to as the love hormone or the bonding hormone. And you can kind of see here, it's a lot more complicated than that oxytocin can potentially play a role in how we relate to each other, sort of in social cognition, in emotion regulation, in understanding and interpreting others' social behaviors, and then also modulating sort of downstream activity in relation to that. So that can also have a downstream effect on serotonin receptors and dopamine receptors as well. All neurotransmitter systems that we all kind of really understand and are interested in when we work in the addiction and mental health spaces. So there are also sort of physiological effects that you can kind of see there that we also are really interested in that may also have some effect when we administer these hormones as medication options. So it's also something that we had an eye on, for instance, in this study, to kind of look at any side effects or adverse effects, which are not what we're specifically interested in, but is that going to have a role as well? So on the next slide, we have some illustration of where we think oxytocin plays a key role. And I think suffice to say, within this study, which we'll talk about in a second, we used an intranasal formulation of oxytocin. You can see there a little depiction of a spray similar to, say, like a saline spray that you might use to say hay fever. So that sort of spray that goes intranasally and then there goes through the bloodstream and then goes quite quickly into the brain. But what we know about the type of oxytocin, the chemical formulation that we have access to within research studies and clinical trials, that we're not sure how much of that actually crosses that blood-brain barrier, how much of that's actually getting into the nervous system, and then subsequently how that actually has a downstream effect in different parts of the brain. What you see there are a range of different regions of the brain that play a key role in human behavior. And for us working in addiction and in mental health, we know that these regions play a really important function within substance use and in recovery, intruding sort of that limbic system, the hypothalamus around sort of memory and function there. And then also what we've got is those responses in relation to emotions and emotion regulation through the amygdala. So all of these different kind of regions have a role to play broadly in behavior, but we also know that they're also sort of what we call secondary or downstream effects lower down that system. And we also know that there are functions that kind of relate to the prefrontal cortex or our thinking, planning, and behavior as well in that space. So for us kind of understanding whether it had a role to play here, we're really interested in particular in that behavioral function, whether we can understand whether it could interface with that in the context of treatment. So within the addiction space, there's been a little bit of research in this space, and as as you can see, when it's been studied in other spaces, in mental health particularly, it's been described as sort of that love hormone or that hormone that kind of promotes bonding or relationships. What we do know is that it increases sort of that potential salience of kind of emotions and interpreting emotions in the context of that. Within the context of addiction, we know that it also kind of modulates that stress response, that stress axis. So here we talk a little bit about the hypothalamic pituitary adrenal axis, the HPA axis, which we know has a really huge role to play in sort of trauma responses and the subsequent kind of responses that we might have if we had a trauma-related mental health problem like PTSD. So there could be a role there in terms of interfacing with that hyper sort of arousal that people might feel in the context of having a trauma response. We also know that from some studies, there's some suggestion that oxytocin can interact with that sort of broader stress circuitry, which plays a role in cravings, for instance, when people are starting to have withdrawal symptoms, and also in that early recovery period where we know craving can be a really strong part of that return or that relapse to substance use. So there is that potential there to moderate that particular cycle. And we also think about whether or not that social kind of aspect of oxytocin, increasing that bonding behavior, what that role can play within thinking about counseling-based interventions. We know that counseling, for instance, is such a central part of our treatment approach within drug and alcohol systems. And so whether or not oxytocin could potentially assist there as well. So there's got us thinking about whether it could play a role in the addiction space. Within the context of addiction, what we know is that there have been a number of small studies similar to ours, small studies internationally, that have looked at oxytocin as a potential treatment. It is an investigational medication, so in the sense that it's not being used on label, it's not being prescribed to people internationally, and actually, it's still even within research trials, relatively difficult to get in terms of the formulation of the drug. So systematic reviews to date have looked at oxytocin as a potential treatment, and a couple of options there include withdrawal-based studies, where we've seen oxytocin being used to look at withdrawal symptoms in that short-term period, and also studies where it might be administered within the context of someone going into a sort of behavioral kind of lab setting. So where, for instance, people are not actually acutely withdrawing, they're coming into a setting where you're actually measuring craving responses or presenting people with drug-related cues and seeing whether oxytocin has a role. And in some of these studies, we saw that did decrease, that people's cravings were actually reduced. We also know that in sort of longer-term studies in substance use more broadly, that we've seen some degree of reducing consumption or use in sort of shorter-term studies. But overall, you can see just from that snapshot that the evidence is still really mixed, and all of the evidence to date haven't been looked at within the context of methamphetamine use specifically. So when we set out to review this sort of evidence, we were interested in its specific role within the context of methamphetamine use disorder. And whilst it's been studied largely in sort of alcohol use in the past, we didn't have any specific comparisons to draw on within the methamphetamine use space. Within opioid use, this is probably the most similar sort of setting where it's been trialed, and that was within veterans with who had opioid use disorder and who were attending a treatment program. And in this study, they also looked at oxytocin within the context of that opioid treatment program for comorbid stimulant use, so people who also had stimulant use in the context of that. This specific study is really interesting, again, because we were, in the study, they were interested in how it actually moderated or modulated the counseling-based intervention, the group therapy in this setting. And so here again, thinking about whether or not oxytocin could play a role in actually helping with the group dynamics within that setting, helping people attend and engage with group therapy, and whether that also then had a downstream effect on stimulant use broadly. So within that study, what they did look at was that there was increased attendance at sessions compared to the placebo treatment, but that within this particular setting, whilst it helped with the group itself and people reporting that the group was better for them, that they didn't actually have any downstream effects on substance use specifically or on craving specifically. So lots more to kind of learn from in that space. Within the context of the area that we're also working in, this study that we wanted to mention, because it's really similar to the kind of work we're doing here, but happened much more recently. So after our study was already in train, was with some collaborators in the US who were looking at oxytocin for PTSD and co-occurring alcohol use. And so you might recall before I was mentioning how oxytocin could have a role in modulating that stress response and modulating stress response in people who might have already elevated stress response in context of trauma. And so within this specific treatment approach, they were taking a therapy called COPE, which is an integrated treatment approach for both substance use disorder and alcohol use disorder. Substance use disorder and trauma, PTSD. So that integrated therapy usually involves kind of 12 to 14 sessions of individual-based therapy. And here they were adding to it oxytocin. What the snapshot is on the right is a snapshot of the protocol papers. They published the protocol paper. The study is actually still in train in the US. It's being conducted across the Department of Veterans Affairs in the US, and is looking at military veterans specifically, so people who have had trauma related to military experiences, and looking at people who've got both PTSD and alcohol use disorder, and thinking about whether oxytocin had an effect both on the PTSD symptoms, but also on the alcohol symptoms. It's a really interesting study there, and something that we're really interested to kind of see what the results look like, hopefully soon. So again, as I mentioned before, very limited kind of research has been done to date in the context of methamphetamine use. And here we've just had a little snapshot of the couple of studies we've mentioned before. And that team previously who'd conducted the research in the group therapy setting here looked at specifically a group therapy for methamphetamine use disorder and manner of sex with men. So it's a specific population who were already attending kind of treatment for HIV-based treatment, and were also then attending this group therapy. And within that context, they saw again that the group cohesion, the group bonding experience was modulated, was improved with the addition of intranasal oxytocin, but again, didn't see necessarily a signal for whether or not it improved kind of methamphetamine use specifically. So again, we're kind of interested to see whether larger scale trials would make any difference. This is a specific manner of sex with men population, so had no women in this specific group, which made us kind of think about what a complementary study could look like in a female population. So in terms of thinking about why women in this space, I guess one of the things you'd had me mention before is that sort of that stress response question. Also, that other reason that we're really interested in this space is within animal research and animal studies, when we have studies that have looked at sex differences and responses, that there are actually significant responses with significant differences in responses to methamphetamine, to kind of the behavioral changes that occur with methamphetamine, to cognitive changes that occur with methamphetamine, and also those effects on those downstream systems, the dopamine and serotonin systems, if you had female as compared to male animals. And so that's particularly from animal research, we see that quite a marked difference. We also see quite a marked difference in animal research and in trauma-relevant differences between sexes. So all of those reasons kind of made us think, well, would the response be any different? Specifically with oxytocin, we also know that the animal research in particular shows more consistent kind of behavioral responses, that social kind of element being more marked in female compared to male animal research as well. The other main reason for us to be really interested in this is we know specifically around methamphetamine that here in Australia, those treatment seeking for meth use has really kind of gone up in women as compared to men. We know that the rates of treatment seeking have gone up overall, but that rate for women has gone up more than it has for men. And we know that also across substance use disorders that in women, what we tend to see is people, first of all, seeking treatment later in the piece often, but also this what we call a telescoping phenomenon, where, for instance, that progression from starting to use something to developing a problematic use to developing a more severe use disorder, physical and mental health problems, and then more severe withdrawal symptoms. There's an element of how that can be telescoped or more severe and progress more quickly. So as a result of that, female-specific studies, women-specific studies allow us to take sort of a gendered but also sex-specific approach to this research and understand whether there is a difference specifically for women in this area. Which led us for the study. And I'm going to hand over to Sarah to tell you a little bit more about our study and how we conducted it and what we found.
Thanks. Thanks, Shalini. So I'm just going to go over the actual study and the results. So as Shalini mentioned, this is an open label pilot of intranasal oxytocin for methamphetamine withdrawal in women. Essentially, it's involving a 7-day residential inpatient withdrawal admission at Wellington House in Box Hill. And oxytocin was self-administered by the participants twice per day, 8 a.m. preferably in the morning and 8 p.m. There were some questionnaires that were completed each day, but other than that, the withdrawal admission was as per standard of care. So the aims, the primary outcome measure of this study was actually feasibility. Being a pilot, we had decided that if the proportion of completed screening visits to those who actually went on to receive a study drug was greater than 20%, then this would indicate feasibility. And we came up with this figure based on a previous study, inpatient study for methamphetamine withdrawal that was quite similar in design to the current study. And that study showed a ratio of 26% of screen completion to study drug administration. The secondary outcomes included length of stay, up to 7 days in the inpatient unit, and the withdrawal symptom severity and relapse rates. Withdrawal symptom severity was measured per day via a few questionnaires whilst in the inpatient facility, relapse rates and treatment engagement at 1 month post-discharge, and as well as safety and tolerability of the actual drug itself. We looked at some exploratory outcomes too, including social functioning and social cognition, as well as mood and sleep, but those have not been analysed yet, so I won't be reporting on those, but I'll discuss the primary and secondary objectives. We recently had our protocol paper accepted as a preprint, so you are able to access this via the QR code if you want any more details on the protocol. Essentially, we received EOIs from our potential participants who then who would have a pre-screen phone call with one of our study staff. And pending eligibility, they would be booked in for a screening visit. So upon consenting to participate and to being referred into the residential withdrawal, the research team would speak with the individuals allocated local AOD services to support the referral to get into that withdrawal unit. At the screening visit, the eligibility assessment would take place with the physicians after written consent was signed. And the eligibility assessment involved full medical history, blood work, etc. So the screening visit was actually designed to incorporate information that's routinely collected during Victorian residential withdrawal intake admissions, intake appointments, and that included a comprehensive assessment done by an intake officer. The baseline assessment would take place post that. We tried to do them on the same day, but the window of baseline needed to be performed within 2 weeks of the admission. So several of those had to be repeated due to delays in receiving bed dates and scheduling. But the baseline assessment involved a battery of surveys and computer tasks. Following that, and within 2 weeks of that visit, was the admission to the Turning Point Addictions Medicine Unit, TPAMU, which is Wellington House in Box Hill, where they would stay for 7 days or up to 7 days, and be administering the oxytocin twice per day. After withdrawal, the participants withdrawal or discharge from the unit, the participants would be booked in for a 1 month follow-up assessment with our team to go over the same battery of surveys and computer tasks that they performed in the baseline assessment. Onto the participants. This was a pilot, so we had a goal of 10 participants. We achieved enrolment of 9 over about a 15-month recruitment period. So inclusion criteria involved being adult female, aged between 18 and 65 years, and meeting the DSM-5 criteria for moderate to severe methamphetamine use disorder, able to comply with study protocol, and to provide informed consent. Exclusion was if people were not fluent in English, if they were lactating or pregnant or not willing to use appropriate contraception, any other substance use disorder, meeting criteria for another substance use disorder, excluding nicotine and cannabis, any unstable medical conditions or participation in another trial were also excluded. Our recruitment figures, our recruitment pathways were primarily via Turning Point referrals, as well as other AOD clinics. We did some mail outs to GPs and also did some social media advertising via the Turning Point networks on X, LinkedIn, and Facebook. So in total, we received 219 expressions of interest, and of those, 46 were eligible and then went on to a phone screen. Of those, 14 were deemed eligible and completed a screening visit. From the 14 screening visits, we had a total of 9 who enrolled in the study, were admitted to Wellington House, and then all 9 also completed 1-month follow-up. The demographics of the participants are displayed here. So the mean age was 37 years, and the range was between 29 and 52 years old. The average methamphetamine use over the last 28 days was 25.4 days out of the last 28 across the group. And that ranged from the minimum was 21 days of use of the last 28, and the maximum was 28 days out of the last 28 days. Years of use, so in terms of the duration, ranged from 3 years to up to 21 years, and 10 years of use was the mean there. 55% had previously sought treatment, and 1/3 had reported using other drugs. Now on to the results. In terms of feasibility, the pilot data indicates that the protocol was feasible. Of the total number of participants that were screened, so 14 participants, 9 went on to receive the study drug, so 64.3%, which is over and above our screen to drug administration ratio of 20%. So, and also the fact that 100% of our participants completed a 1-month follow-up. So as I mentioned earlier, this 20% ratio figure was deemed to be feasible based on a very similar study using lisdexamfetamine for methamphetamine withdrawal in the context of a residential withdrawal. And they achieved a 20%, 26% ratio. So we're pleased with that. A secondary objective was to look at the length of stay in the inpatient withdrawal. So inpatient withdrawal is usually a first step in the recovery process, but individuals with MORD often have high rates of unplanned discharge. So in previous research, the mean length of stay has been 5.5 days within the Turning Point residential detox programs. And another 10 years ago, a paper was published by Rebecca McKeaton, who is one of our co-investigators on this trial, who was assessing the impact of community-based treatment options. This was called the MATE study, the Methamphetamine Treatment Evaluation Study, and that assessed 112 participants, and was found that the median stay in a detox facility was 5 days. So we we can report that our sample, there was a mean of 5.44 days on average out of the 7. And of those, and then at follow-up, 55% had engaged in their post-discharge plan. Another secondary outcome was relapse rates. At baseline, our participants had a mean days of use in the last 28 days of 25.4 days. And at follow-up, this was reduced to 19.33 days out of the last 28. In the whole group, 7 out of 9 had relapsed at follow-up, so that's 78%. 5 reported no change in their methamphetamine use. 2 had become completely abstinent at that point, and 2 had reduced their use on an average of 4.5 days out of 28. The withdrawal symptom severity was assessed each day by questionnaire in the inpatient period. And the amphetamine withdrawal questionnaire is 10 questions relating to anxiety, craving, agitation, fatigue. And this scale is scored on a range of 0 to 40, with higher score reflecting greater withdrawal symptoms. So as you can see, it's fairly mid-range throughout the study, with a large drop-off at the end. However, we did only have 2 participants who made it to the full 7 days. So it's maybe not indicative of everybody. Onto craving, we used a 100 millimetre visual analog scale to indicate severity of craving during the inpatient studies. This was taken each day also, and participants were asked to indicate how much are you craving methamphetamine right now, with 0 being not craving at all and 100 being unbearable cravings. And just got a line graph here to just sort of illustrate the variability of responses we received over those 7 days. So you can see one participant, each line represents a different participant, but one participant was very severely craving throughout their entire time. Some it was quite variable, being a huge increase and then withdrawing at this point of day 5. We also had quite a lot of missing data where some responses were not recorded. But of the 2 participants who did stay until day 7, they had a fairly lower level of craving throughout. That's just a little illustration of the data. In terms of the safety and tolerability of the medication, we didn't have any serious adverse events reported throughout the study. And we did have 19 adverse events reported. Of those, 15 were deemed to be mild, 2 were moderate, and 3 were severe. However, 2 of those 3 were later downgraded to moderate and severe. Essentially, one of our participants was experiencing night terrors and sleep paralysis, was taken to the emergency department, but was taken back to Wellington House later that evening. So we've deemed that to be not due to the drug. And the most commonly reported adverse events were headache, body aches, and back and abdominal pain. And this was reported in 5 out of 9 participants at numerous time points across the week. We further investigated this as it seemed to be quite common. So we've had a deeper look into what we were seeing and thinking that it could be relating to menstrual or abdominal cramps, given we know the effects of oxytocin, particularly during childbirth, etc. So we thought it was worth a deeper look. But upon further investigation, it was noted that the abdominal pain was really only reported in 2 out of the 5 of those reporting pain, and the rest were more due to back pain and general body aches, etc. So these were deemed not to be due to the study drug, but likely to be an expected withdrawal symptom from methamphetamine. So I will just pass back to you, Shalini, to go through the challenges we saw.
Thanks, Sarah. So we've done a really quick flyover, I guess, of some of the results, but we wanted to have an opportunity to kind of highlight some of the broader kind of systems challenges that all of us who kind of do clinical research in this area are really aware of. And I think for a study like this, particularly within the context of a specific, like a residential withdrawal unit, really important for us to kind of keep in mind for these types of studies. And so one of the main reasons, some of the participants, some of the attendees might be thinking about why we'd do such a small study, I suppose, like a pilot with, our aim originally was 10 to 15. And some of the challenges, I guess, not listed even on here, is really that sort of pathway into kind of doing pharmacological studies within the kind of drug and alcohol space is really also challenged by, I suppose, the lack of sort of investment or pharmaceutical industry involvement in kind of looking at medication treatments for something like methamphetamine use disorder. So even kind of getting the medication and the expense of the medication are really kind of amplified in the context of some of these sort of disorders. Partly this is because of the stigma that people who use methamphetamine face within the treatment system, and that has that downstream effect also in pharmaceutical companies being somewhat less interested, I suppose, in investing in these types of spaces and thinking about treatment. So for us, we mentioned that the study actually got funded prior to COVID back in sort of 2019, 2020. And the subsequent kind of delays for us to even get started were partly also due, and mainly due to kind of access to the medication itself, to oxytocin, trying to be able to access a product, get it made up for supply that we could administer it within a clinical trial such as this. And so COVID-19 had a real impact on those delays, but also I think impacted on our capacity to be able to do a larger sort of scaled study as well, and became quite expensive. And so as a result, we kind of thought about how can we learn as much as we can from this type of study, and how can we also focus on, if we have a study like this that's kind of aimed at optimizing that withdrawal period for people, what are the sort of things that we want to be thinking about in terms of key learnings? And that's one of the things that you kind of see demonstrated on the screen, is thinking about how feasibility in a study like this is kind of operationalized, how we think about what we can learn from this for future studies. So what we really saw in this study was that lots of people were interested. You saw those previous kind of consort flow type diagrams where we had lots of EOIs completed, expressions of interest completed online. But those didn't always translate to kind of eligibility. There were a whole range of reasons for ineligibility, which include things like, for instance, we got males also on our screen. So that was probably one of the very quick ineligibility criteria, given that the study was for women only. But also we had people who weren't interested in kind of coming into an inpatient withdrawal setting for an inpatient withdrawal study. That was the next period, next point of call. But also more broadly, one of the challenges for people who were broadly eligible as well is also thinking about the impact of other substance use disorders as well, so comorbid substance use disorder. And that's really something that we've seen kind of increase in the last kind of 3 or 4 years. It's for people who use methamphetamine that comorbid other substance use, particularly GHB, was really, really common, and was a high reason for kind of ineligibility in a study such as this. So I think for us, it does mean that we want to be thinking quite broadly about the types of studies we run and whether it matches the samples we're seeing. But this type of study being a small pilot and very early on in that pathway of does this have any use in stimulant use, we're kind of limited by that sort of ineligibility quite a bit. In terms of those other challenges, we had people do the screen and then the baseline and then kind of wait for admission date. And again, we were kind of thinking about this type of study within a routine care setting. So people coming into an inpatient withdrawal environment, and all of the sort of stuff that goes around that. So doing an intake assessment, for instance, waiting for a bed date, getting that sort of confirmed. Also having that bed date also relate to a post-withdrawal plan. So broadly across inpatient admissions across our state, across Australia, we really kind of try to maximize that likelihood of people being able to engage after an admission with ongoing recovery supports. And so being able to kind of coordinate that all around an inpatient admission, we kind of really had a bit of a shining of a light of, I guess, that sector coordination kind of difficulties that we have across our treatment system. So people kind of waiting for an inpatient bed, but perhaps also then waiting for a rehab bed after inpatient admission, or for instance, trying to coordinate this inpatient stay with counseling or other supports after the stay. So all of that kind of often resulted in sort of iterative kind of bed dates being confirmed, and then subsequently, trying to redo kind of a baseline admission, baseline assessment as a result of that. So I think, in part also the feasibility of doing clinical research like this is also speaks to that broader kind of challenges within our treatment system, within the drug and alcohol treatment system, and the fact that we often need to be very pragmatic and flexible, both as clinicians and as researchers working within the system, but really ask a lot of, I think, participants and ask a lot of people with substance use disorders to be able to kind of coordinate these sort of journeys by themselves. And a study such as this really, really highlights that as well. Let's go into our next slide in terms of what we're thinking of as next steps as a result of that. One of the things that this has really kind of highlighted for us and for other collaborators in the context of an inpatient withdrawal setting is also thinking about how we actually stitch all of those system supports up in a way that people are actually accessing that, aside of whether or not we add a novel treatment into that approach, but also thinking about how that system coordination and support is so key to be able to optimize that whole withdrawal process for people. Regardless. I think the other second key point that we're interested in is, as a next step, I think for studies such as this, thinking about larger sample sizes, larger studies are really important. But also, I think we're also wanting to draw on other pilot data where we can do a larger study. And so we mentioned before the lisdexamfetamine study, on which the feasibility comparator was for this study. That lisdexamfetamine pilot was conducted at St. Vincent's in Sydney during COVID, actually, like 2019, 2020. And that pilot data from that study went on to support a larger powered grant application, which was successful. And so we're very lucky to be able to then see that scaled up into a larger multi-site study. So our site in Melbourne, Turning Point in Melbourne, will be a site for this next year, and I think possibly St. Vincent's in Melbourne as well. So we'll have a couple of sites in Victoria that we'll be able to recruit to lisdexamfetamine for methamphetamine withdrawal. And again, this will be an inpatient withdrawal study. So thinking about how, again, we kind of navigate those feasibility barriers that we touched on before. The other thing that we're really interested in kind of exploring within the methamphetamine space, as I mentioned before, thinking about both comorbidity and also thinking about comorbidity with mental health disorders is really kind of key in the space. We know the really high rates of sort of anxiety, depression, PTSD within the context of people who use methamphetamine regularly. So thinking about treatment approaches that are going to address all of this together and potentially within outpatient extended withdrawal setting. We already have sort of really great counseling approaches that already kind of try to stitch up some of this, but thinking about how we actually add medication treatments to these approaches to actually optimize that can also be a next approach for us, I think. So on that point, what we might do is just kind of bring that to a close so we can go through some questions, and really happy to share the slides and also a copy of the protocol paper with everyone.
Thank you, Shalini. Thank you, Sarah. That's some really interesting findings, and there's clearly so many learnings about the challenges and difficulties of running medication trials in real-world settings. And I mean, I guess one of the thoughts that came to mind was, this was largely a sample who had, I think you said you showed 50% had previous treatment, but was it were they new to withdrawal? A with inpatient withdrawal episode?
Largely, and I'll throw to Sarah to kind of jump in, but I think we had quite a mixed sample. So there were a number of people who'd done a number of residential withdrawal episodes before. Mm-hmm. Sarah, did you have anything to add to that?
Yeah, I can't really remember the details exactly around the previous treatment experience, but there was definitely some who had gone through several detoxes and some who were fairly, 45% were naive to treatments.
Yeah. We've got a couple of questions. The first was around the ineligibility. So I think there were 5, wasn't it? They didn't make it through. Do you know about the reasons for that, why they were ineligible?
They ranged. I think there was a bit of comorbid substance use as well, which wasn't picked up at pre-screen. Upon hearing a bit more about the study, some people just opt out. They're not interested in the inpatient detox. We did have 1 pregnancy, so it was varied. Yeah, I don't think there was any standout in terms of the screen failures, no.
Yeah, but I guess we've always got that challenge of when people are willing to come in for withdrawal and when there's actually a bed available and other, things, life factors that changing circumstances that really kind of interrupt those planned admissions. There's another question about the co-occurring, wondering about MOXY for people with co-occurring low prevalence mental health disorders.
Yeah, that's a really interesting question. I guess that kind of just clarifying that, probably assuming in the context of psychotic illnesses or bipolar illnesses, and oxytocin's been one of those medications that's been trialed in a whole range of different mental health problems, just in and of itself, aside from co-occurring addiction. So certainly a space that I think bears fruit, and I think within the context there, I mentioned, for instance, co-occurring PTSD measures that we haven't analysed yet, and so that was something we were specifically interested in. I think one of the main barriers in terms of scaling research like this, we often in that clinical research pipeline will do a small study such as this to really kind of learn about what are those little pipeline points, what are those tipping points, those pressure points, before we do a bigger study. And for us, I think this type of study, particularly with the specific investigational product, would just be too cost prohibitive to actually roll out in any implementable form. We were really helpful when we started doing the study. One of our initial co-investigators was working on a synthetic analog for this that could potentially be more cost effective and also potentially more viable and kind of crossing that blood-brain barrier. So that's still in development, and we are hoping that that's the kind of future, I think, for medications that continue to target these specific receptors. Is probably thinking about that next step about how do we access a product that's actually going to be cost viable, but also potentially more effective as well physiologically.
Yeah. So what would be your sort of, I guess, summary in terms of using oxytocin as a potential medication for future, if it was cost, if it was cheaper and easier to administer, and we had a ward or an inpatient unit, perfect scenario here. Based on what you've found from these 9 participants, would you want to continue exploring its efficacy?
I might take a first stab and I'll check what Sarah thinks. Being partially on the ground trying to run this, I think one of the things that we heard, I think, a lot from our participants too is a real interest, I think, also in exploring new approaches, like medication approaches that target the withdrawal and craving aspect that are very intense with methamphetamine in those first early recovery period. But we know that the early recovery period isn't that 5 days, it's 7 days, it's longer than that. And so for us, I think what would be exciting if we had opportunity to explore something that we could cost effectively would be a longer protocol that included that sort of early remission, early recovery period. So probably something that was more in an outpatient setting that would be 3 to 4 weeks. I think that time period really allows people to be able to kind of engage in counseling approaches at the same time as well, and hopefully the 2 approaches can work in tandem. So that would be really exciting to see if we can find something that allows us to do that.
Yeah. What was I thinking then? It's escaped me. If it perhaps another environment might be a sort of resi rehab where you could actually, a longer sort of stabilization residential rehabilitation program where you could then look at the impact, as the other studies that you presented have done, on bonding with other clients. And that's what I was thinking. When I noticed that I think 7 or 8 of them lived with other people. and how sort of long does that bonding effect or that sort of connection effect, that pro-social effect last? So if they were discharged and went home to family, could that improve relationships? And were there any measures in the study that looked at connection with others post-discharge? I can't remember.
So one of the things to know, I guess, like with this specific, and yeah, totally, Sarah, because I keep jumping in. I think with this specific medication, it's quite short acting actually. This formulation, and so we also, so when we think about short acting, I think we're looking at those very immediate kind of behavioral effects that we can kind of measure. We actually don't know too much about those longer term kind of downstream effects that could be set into play. But in this specific study, we looked at also treatment kind of alliance or working alliance with the nursing staff, the teams in the unit as well, whether people kind of felt, how they were actually supported by the team that's around them, which it can also be a very important aspect of kind of, staying in a withdrawal unit. I don't know if you had anything, Sarah, to share. We've got some other measures that we haven't analysed yet.
Yeah, we've looked at social functioning and social cognition using a couple of different tasks, and we haven't quite looked at that yet. But given the short-acting nature of the drug, it's unlikely, probably, that there would be much change up from baseline to follow up with those tasks. Perhaps if we'd looked at them more acutely during the inpatient, we may have seen something, but it's hard to do these kind of measures in an inpatient facility. So something to think about for the future, maybe.
We've had a few more questions come in now. So Josie was asking about nicotine dependence and if they were given NRT during the episode and whether that would have any impact on how oxytocin's working.
Yeah, so this is a smoke-free withdrawal environment. Yeah, so everyone received NRT if they were smoking prior to coming in. And I guess in terms of whether or not that affected, we don't have any sort of theoretical basis for kind of exploring that necessarily, but we may have. It's a good question. We could go back and look in our own sample, tiny sample, but we could still have a look and see if there were any differences within smokers and NRT and not. That'd be really interesting.
Yeah. And do you have a sense of, another question relates to the frequency of their methamphetamine use prior to admission? Do you know, were they sort of daily or weekly users or more like once or twice a month? I think it was moderate to severe.
Yeah, it was quite often. I think the least amount of use in the previous 28 days was 21 days out of those 28. And the greatest was every day of the last 28 days. So the average was about 25 days out of the last 28. But that's, I think, the actual amount, dosage, I guess, of the methamphetamine varied, but we haven't really looked at that in any detail. We've just looked at days. But I think also duration of use as well is an interesting factor to be putting into the equation too for when we do some more kind of in-depth analysis.
And we have a question around the reason for why some participants didn't want to enter an inpatient withdrawal setting. Was anything to do with the gender and the fact it was a mixed ward?
Hard to know in this sample because I guess that we kind of most of recruitment was based on a women-specific study and flagged in the recruitment criteria that was for an inpatient withdrawal. But certainly we can speak to the fact that for a number of participants, really arranging kind of family arrangements, kind of childcare. As we see for women across the board, major barrier to kind of booking bed dates and for thinking about post-withdrawal plans as well. I think that inpatient withdrawal setting is not always set up in a way that allows that flexibility or capacity for people to work around that.
Yeah. And the last one I have here is around whether the two that did complete all 7 days, if they had any similarities or if they were distinct from the other 7, or have you not? Probably haven't had a chance to look at that yet.
They did have the highest rates of treatment satisfaction. So that's an interesting finding, and also probably amongst the lower of craving overall. But again, I haven't looked into it in any really deep detail. But I think there probably may be, yeah.
Fantastic. Well, I don't see any other questions. So I'd just like to say thank you for such an interesting talk and for sharing those insights about, you know, the challenges of running medication trials, particularly in withdrawal settings. But it's really important work, and I'm really pleased that you managed to complete it despite, you know, challenges getting the medication and COVID. And yeah, so well done, and thank you so much. And unless there's any final questions, I think we'll call it a day and see you next month.